So, hello, welcome everyone. I will be speaking about the, oh, sorry, you wanted to say something.
Hello, yeah, sorry. Now Dr. Meghana Varde will speak about reconstructing the missing pieces, eyelid reconstruction and congenital eyelid deformities. So she is a consultant at Cantonal Hospital St. Gallen in Switzerland.
Thank you. And thanks for inviting me for this nice instruction course. So I'm having the pleasure about talking about reconstruction in congenital eyelid deformities, and my job has become much easier with the people who were presenting before me, so I don't really have to go into details much. I don't have any financial disclosures, and I would recommend you not to take any photographs, because otherwise the lion will come. So congenital eyelid deformities can be classified into four pieces. So there are abnormalities of eyelid division, tissue defects, malpositions, and lesions, which can present at birth or soon after birth. So what do we as oculoplastic surgeons do? This is an image of painting a face with your eyes. So what we see over here, can I have the pointer? So what we can see over here is actually that the periocular area is the one that is most important when we look at somebody else's face. So what we are doing is not only aesthetics and functional, but we are also actually doing a rehabilitation for the patient to work and to function in his normal habitat. So in congenital deformities, it's always about the indication and timing of surgical correction. So you need to see what is your aim of the surgery, whether it's clearing of the visual axis, maintaining the integrity of the ocular surface, or cosmetic rehabilitation, as I have said. So like that, the surgical correction can be planned, sometimes necessary in the neonatal period, if there is really a problem in the ocular surface. 6 weeks is a time when mostly the kids are more ready to be taken up for general anesthesia, as well as 6 months or at 5,000 grams of weight. Then at 2 years, when the facial features and the facial skeleton is actually developed, or 4 to 5 years before the initiation of school, if it can wait that long. And then as a teenage or as an adult, if you want to do a correction, when the patient is able to endure a local anesthesia and comply for the surgery. So I just want to firmly touch on the embryology of the eyelids. It starts after the first month with the lens vesicle developing and the surface ectoderm invaginating on top of it, then forming two folds of surface ectoderm, which is basically driven by the mesoderm, which is pushing it forward. At 5 weeks, I can't really, okay. At around 5 weeks, there is a complete fusion of the eyelids, and that time, 8 weeks to 5 months, and that time is actually used for the eyelid development, of developing all the eyelid structures, the adnexal structures that we know in the eyelid, and also for deforming the anterior segment of the eye. So eyelid separation happens just 5 to 7 months, at 5 to 7 months, which is just before birth. So in this time, there is a possibility of developmental eyelid malformations, which is mainly failure in development of the folds, which can lead to any form of cryptophthalmus, failure of the separation of the eyelids, which can lead to any form of angular blepharon, and interruption of the eyelid folds, which can lead to any form of coloboma. There are lots of systemic associations with cryptophthalmus. These are the three main associations. They are mostly epidermic malformations, which can be mainly the face, or it can also develop or it can also incorporate heart problems, genitourinary malformations such as imperforate anus, and subglottic stenosis, which can also be life-threatening. So these three are Fraser syndrome, Mota syndrome, Manitoba being a place in Canada, as I've read, and ablepharon-macrostomia syndrome. There are a few other syndromes also associated with it. Many of them are autosomal dominant inheritance pattern. So do we need to look for associated syndromes and genetic disorders in cryptophthalmus, which we all know is always very intensive in investigations? So this is a very recent paper from the Katowice group from 2023. And they've looked at ocular malformations and underlying systemic disorders, and they've identified in nearly all cases of unilateral and bilateral cryptophthalmus that there was something associated. So they are actually presuming, or they are advising, that a comprehensive genetic evaluation should be done for all children with unilateral or bilateral cryptophthalmus. There is another interesting paper which has come out recently, ophthalmic features and management of 86 patients, which are about 112, I think, cases, to assist in surgical planning in cryptophthalmus. So depending on the visual potential which they have found in these kids, depending on the electroretinogram VEP, if the visual potential is there, the integrity and protection of the globe, of course, is to be prioritized, which also reflects in your management of the case. So in this paper, they have classified cryptophthalmus into complete, incomplete, and abortive, and I'm going to give you examples to each one of them. So these are two examples of complete cryptophthalmus. This is one from the Pediatric Oculoplastic Surgery book. This is one from this paper, where you can see that there is a smooth surface of skin overlying the eye, completely from the forehead going to the cheeks. And in this case, they did a complete reconstruction of the anterior segment as well of the lids, which unfortunately didn't give the patient any benefit. This was done after ERG, of course, and VEP, and thinking that there is visual potential. And in this case, actually, they also saw that there might be visual potential. They did basically the same thing, and apparently this patient is having ambulatory vision. So not all is lost in these very bad cases. In a case like this, cryptophthalmus can be associated with microphthalmus and with microphthalmus with cyst. And in this case, it's bilateral, but asymmetric. So they have actually, with the cystic globe, which doesn't have any visual potential, there is a potential of cosmetic rehabilitation. So the authors hypothesized that until the age of 7, there should be a cyst reduction done, because the cyst in itself is actually also helping in skeletal growth and growth of the orbit. From age 7, you can actually excise the cyst, put an implant, and we can discuss about whether it has to be hydroxyapatite implant. And a socket reconstruction can be done with mucous membrane grafting and local flaps for it to be able to hold a prosthesis. So these are pictures from my fellowship of incomplete cryptophthalmus. Incomplete cryptophthalmus actually having a lesser degree of visual potential, as in this child, and always having a fusion of the upper eyelid towards the ocular surface. So there are different options of reconstruction. Again, for the posterior lamella, mucous membrane can be used. Amniotic membrane can be used. Canthal suspension with a tassel strip or a periosteal flap. And for the anterior lamella, flaps, grafts, and tissue expansion has been discussed by my previous colleagues. This is a case of abortive cryptophthalmus. This is the least severe of the cryptophthalmos cases, there is a mild, moderate, and severe form. So this might be a severe form of cryptophthalmos with an adhesion of the upper lid also to the ocular surface, but the ocular surface being able to be reconstructed, as in this case. So Dr. Subramanian had used the switch flap from the lower lid to reconstruct the lid, as well as PK has been done. Unfortunately, I don't remember what the vision in this eye was at the end of the surgery. So the mild cases of cryptophthalmos, of abortive cryptophthalmos, cannot really be differentiated from eyelid coloboma, which can also be due to failure of migration of ectoderm, mainly because of amniotic bands or any kind of other systemic associations which we will see. Most often, the upper eyelid is involved. The syndromic associations which we have to keep in mind is the Charge syndrome, coloboma, heart defects, choanal atresia, and genital abnormalities, and Golden Hair syndrome. Management involves most of the time director positioning, as in this case. Sometimes you can use a lateral canthalysis, which was not required. There is another syndrome called Treacher-Collins syndrome. It's a dysmorphosis syndrome, which has a pseudocoloboma of the lower lid, and the reconstruction is mainly with a switch flap from the upper lid. This is a case of ankyloblepharon filiform adnatum, and actually the surgical management is very straightforward with just cutting of these filiform adhesions. But one has to keep in mind that in type 3 and in type 4, there might be syndromic associations which can actually also be life-threatening. Can I come to craniofacial clefts? So it's just a little bit. So about craniofacial clefts, there is a failure of fusion of the facial prominences and a failure of mesodermal penetration. Most of the cases are sporadic. And there is a classification by Tessier about craniofacial clefts, some of them involving the eyelids, the lower lid and the upper lid, and some of them also, number 3, number 4, involving the nasolacrimal system. So in these cases, many a times, switch flap techniques can be used, and the medial canthal reconstruction, just like Dr. Hedge had told us about. So this is one of the cases that we had. I think I will skip the lid malformations in this case. Epicanthus has been already addressed. And just for the nevus, I just wanted to say that there is only a very slight chance of malignant transformation. The reconstruction after excision, if wanted for cosmetic reasons, can be done by the normal ways. So as a takeaway message, the abnormalities in the fusion and division process will lead to eyelid division, defects, tissue defects, malpositions, and can also lead to lesions. Associated syndromic manifestations have to be found. Reconstructions will follow in the same lines as we know, and the timing of surgery needs to be taken in account. Conservative measures can be used in most cases for buying some time. Thank you.
Thanks, Meghana, for illustrating the entire spectrum of pediatric congenital anomalies.